and thank you for the short introduction because we're going to be running pretty quickly here tonight. Thanks for that, and welcome everyone. Thanks for joining us this evening, especially those of you in the Eastern Time Zone where it's already 8:30. We're going to get to it right away. This is a 1-hour webinar, and the first thing I'd like to do is thank our sponsors. Lisa mentioned Shofu Bisco and Pathetic Aesthetic Lab Group. Bisco and the lab will have a few quick words right at the end of this. Shofu is not with us tonight, but they're all great companies. I've worked with these companies, both Shofu and Bisco, for many, many years. I love their products. One of the things I like about both of them is that they have products that have ion release, and as time goes on, I think we're starting to see more and more of the benefits of ion release in certain materials. And unfortunately, I don't have a lot of time to talk about that tonight, but it's certainly worth looking into. If you're not using their products, I highly recommend you doing so. I'll talk a little bit about them as we get into the webinar. The Pacific Aesthetic Lab Group has been my lab for many, many years, over 20 years. I've worked and taught with them. They're a phenomenal lab, and I'll be talking about them as we go through this program because you're going to see a lot of the cases that they've done for me, and I'm just going to refer to them as my lab. So it's a lot easier to say my lab. So when I say my lab, I'm talking about Pacific Aesthetic Laboratory Group. So this is what this webinar is. It's basically 4 hours of material that I'm going to endeavor to do in 45 to 50 minutes. Okay, so I don't have time to go into a lot of detail. I'm just going to try to hit some high points. I'm going to try to give you a kind of condensed version of what we have available through Catapult through this modular series. In the 4-part modular series, it's a comprehensive course with a lot of information. The 4 modules are minimally invasive preparation for porcelain veneers. Module 2 is great provisionals, the key to success in anterior aesthetics. Module 3 is smile design principles, combining art and science. And Module 4 is adhesive resin cementation of non-retentive restorations. So what I've done is I've condensed these 4 modules down into this webinar tonight to try to give people that are interested kind of, pique your interest a little bit. And if you want to learn more, if you want more detail, Lisa can give you all the information about the modules. And if you really want to learn, if aesthetic dentistry is a love of you, or you're passionate about it as I am, I can't say in enough words the value of a live patient hands-on course, which we'll be teaching this fall at University of Alabama Birmingham School of Dentistry, supported by Catapult and Catapult Grow. And it will be, the dates down there on the bottom are November 8th and 9th for prep, and December 6th and 7th for seat weekend. You bring a patient, you're going to do 10 veneers. My laboratory will be there supporting this program. You get tremendous education value from this. And if you're interested, obviously you can talk to Lisa about this, about the possibility of really taking your skill and knowledge and expertise in aesthetic dentistry to another level. So let's get into it. We're going to start with the minimally invasive preparation for porcelain veneers. This is where it all starts, understanding ideal tooth preparation. And before I start the preparation discussion, I want to talk about real quickly what I call the porcelain veneer mystique. And I think this is important to understand because it involves what I think some dentists have a misconception about veneers, where because they haven't had success or because they didn't learn what I'm going to try to show tonight and what we try to show in our courses, proper prep design and how to bond restorations on. They haven't learned these type of things. They think that they're not successful. I've had patients come to my office many times and they've said to me, well, my dentist wants to do crowns because they say veneers don't work. Well, part of the problem is understanding proper tooth preparation, which I'm going to touch on briefly here in just a minute. Also, you got to understand what makes a smile attractive. And that's what we teach in smile design principles, understanding what's the difference in certain things, not just the art, but also the science behind making smiles attractive. And then the third thing is, how do you successfully bond non-retentive restorations, which a porcelain veneer is? Obviously, we know with a retentive prep, a crown's always going to work because rarely do they come off. But a porcelain veneer is a non-retentive, and it has to be bonded on properly. And we'll talk about that at the very end. But if you understand these concepts, you're probably never going to have to worry about a veneer coming off, or getting discoloration because of micro leakage, or post-op sensitivity, and these type of things that make dentists kind of shy away from these procedures sometimes. So I'm going to say this one more time. I'm going to apologize. I'm going to be going a little fast here. So, put a question in the chat box. We'll try to address them if I go too fast, but just really just trying to hit some high points for you here. So this is our preparation philosophy. I've been teaching hands-on programs for over 25 years, and this philosophy has not changed. So if you want to know something, if you talk about materials, they're changing all the time. They change, daily, weekly, monthly, yearly. I mean, they're always changing. New materials are coming out, new adhesives are coming out, new cements are coming out, but preparation philosophy is pretty much staying the same. So establish incisal edge position, establish arch form, then we do our depth cuts and facial reduction, our interproximal elbow, our lingual finish line, gingival margin placement, and rounded internal line angle. So that's our philosophy, and we're going to go through these step by step real quick for you here. So Galib Gurel said in his book, The Science of Our Porcelain Veneers, the incisal edge of the maxillary central incisor is the most important determinant in the creation of a smile. The position of the incisal edge acts as a parameter upon which the rest of the treatment is built. So if it's that important, which I believe it is, and which we teach this, we always want to start with incisal edge position, and we want to establish that first before we ever think about prepping teeth. And a lot of times what we do and what I do, what's worked so well for me over the years is looking at the lips at rest. And that's how we use this technique for determining incisal edge position. And in the module, I go into this in more detail. And certainly in our courses, we spend a lot of time talking about how we establish incisal edge position because it's so important. The next most important is creating proper arch form. Well, sometimes it already exists. And if so, you're off to a really good start, but rarely is that the case. Sometimes it might be established with orthodontics. Sometimes ideally you'll have a diagnostic wax up, which I'll show in a minute. But if you need to establish arch form and you don't have a diagnostic wax up, you can do it with a direct composite mock-up, which because before porcelain veneers were even available, I've been a dentist for so long, I used to do a lot of direct bonding. I don't do as much anymore because I'm a big fan of porcelain veneers. I do some, but if you've ever done a lot of direct bonding, doing a direct composite mock-up is not that hard to do, really. So sometimes we do those, but most of the time what we recommend, and certainly what we teach in our courses, is the indirect composite mock-up with a putty matrix, and I'll show you how we do that. So here's an example of an arch form that if I'm doing veneers here, which we did, I wouldn't want to start depth cutting right now. I haven't established incisal edge position or arch form. So what we're going to do with our arch form is we're going to refer this patient for some other reasons, but also because of some constricted arch form. And we want to go ahead. You see the purple lines, the black lines where we are, the purple lines where we'd like to be. So after orthodontics, you can see we've established a better arch form here. And now we're in a much better position to minimally invasive tooth preparation. This is an example. So here's a case that came in, and I don't know what the reason. A lot of times you're in a hurry, or the patient's in a hurry, or they've got a wedding or some kind of function coming up, and we don't have time to get a wax up. And so we're going to go ahead, but we have length width ratio issues here going on. We got gingival height asymmetry here. And we got, arch form discrepancies here. If we see the blue line's the ideal arch form, you can see a lot of these teeth are lingual to where we would like them to be. So we're going to be building these out. This is actually a good thing. And the reason it's a good thing is because this is more an additive procedure where we're not having to reduce a lot of tooth. In fact, the central incisors are probably the only tooth, and maybe the canine on the right side is about all we're going to be reducing. So we're going to go ahead and put some composite on here. We shape it, and now we've gone ahead and we've established our length to width ratio that we would like. We've established the incisal edge position, gingival height symmetry, and you can see we've got our better arch form where the teeth are now ideally where we'd like to be. And then we can go ahead, we can take an impression of this mock-up, set that aside, and then we do our depth cuts right through the mock-up, so we're not reducing teeth unnecessarily. And that's the big key. When you establish your arch form first and you depth cut through the established arch form, then you take off the mock-up material, then what's left is sometimes a lot less tooth reduction. So with an indirect mock-up, indirect composite mock-up with a putty matrix, you're going to start with a diagnostic wax up, and then my laboratory fabricates beautiful diagnostic wax ups. I am so, it makes my life so much easier because they do such great wax ups, and they give us these prep guides. The one on the left is a facial reduction guide, and the one on the right's incisal reduction guide, and then the putty matrix. They take a Seal-Tech putty and then they reline it with a light body to give you really good detail, which you'll see in some provisionals, which I'm going to show you in the next segment, where we talk about provisionals and what beautiful provisionals we can get with these great mock putty matrices. But we also can do a great mock-up as well. So here you see a case where you see, again, these teeth are lingual to the ideal arch form. So we place in our facial reduction guide, and we can see we're going to be building these teeth out. So we're going to go ahead and we're going to take our putty matrix, and we're not going to spot etch. We don't want them to stay on. We want to be able to get this material off. So it's just going to lock into undercuts. We just dry the teeth, put our temporary material in the matrix. We seat it over the teeth. We wait a couple of minutes. We take it out, and now we have the matrix. We have the mock-up done. It's a little bit more material than what you need. As you can see, we have a lot of excess, but it doesn't matter because all we're doing is we're establishing our arch form, and we can go ahead and do our depth cuts, like I said, right through this material, and so we're ready to go with very minimal tooth reduction. And so when we do our depth cuts, that's our next step after our facial contours have been established. There are two types of burrs. One has a single cutting tool like you see right here, and some burrs have the 3 cutting cylinders on it. But regardless of what you're using, you have to be sure you angle the burr so you get to the depth of the cylinder. So you can see I usually make 3 depths. I make one in the gingival third, one in the middle third, and one in the incisal third. So we make these 3 depths, and they look pretty depth magnified right there, but this is a 5/10 of a millimeter depth cutting burr. Sometimes we'll use a 3/10 of a millimeter in the gingival third, and we'll use a 5/10 of a millimeter in the middle third and incisal third. That's why I like to use the single cylinders, because I can use a smaller depth cutting burr in the gingival third where I don't need as much tooth reduction. So after we do our depth cuts, we color them in so we can see exactly where those depth cuts are. We take a chamfer burr, we just follow the gingival margin, and we reduce until the color is gone. So we create a chamfer equal with the gingival margin. And then after we prepped all the teeth, all the color is gone, your facial reduction is done. And then we're going to create our interproximal elbow. Our elbow is the area of the tooth below the interdental contact. So the black line you see there is the interdental contact area. The colored in area is where you want your elbow. So we just take this burr and we just raise it up as we're going around the gingival margin, and we just raise it up so the tip of the burr kind of rolls in there. And what that does in this area right here, if the patient is the veneer is viewed from the side, you don't want the margin coming down here. You want that margin to dip in so that you don't see a discoloration if you seat the veneer and the patient turns to the side and somebody sees the tooth from the side. So you're not breaking the contact, but you're just kind of hiding that margin interproximally. Our lingual finish line is a butt joint margin. You can see here depicted in the thing, it's a 90-degree margin on the lingual. It's going to, when you just flatten this incisal edge, if you want an 11 millimeter central incisor and you have an 11 millimeter central pre-op, then we're probably going to want to do about 1.5 millimeters to 2 millimeters of reduction. So this would be about 9 millimeters right here. If you have a 9 millimeter tooth, you don't have to do any incisal reduction. You just flatten the incisal edge. But you have to come back later and you have to round this facial incisal line angle because you don't want any sharp internal line angles. The veneer just fits flush right here on the lingual. It just sits, so you got the little tip. When you seat this veneer, it just seats right against the incisal edge. It gives you a positive seat, which is really nice. And then our gingival margin placement, you're going to have subgingival, equigingival, and supragingival are the 3 margin placements. I'd say about 99% of the time, we're using equigingival now. I don't ever do supragingival. That was kind of popular many, many years ago. Subgingival, I'd only do if there's decay or some type of restoration or something that goes below the gum line. That'd be my only reason for doing subgingival with the aesthetic materials that we have available today. So let's look at this really quick. Kind of give you an idea of what we just, in a little quick video here. So I'm going to talk through this. So what I'm doing is I'm just looking at the incisal reduction guide. I can see this is made from the diagnostic wax up. So we're going to be increasing length slightly. So I'm not going to have to take as much off the incisal. If these are unprepped teeth, it would be a little bit different, but I'm just go ahead and tell you this is a case that we did. where they had old veneers were going to be taken off. But you can also see there's some room here facially. We're going to be building these teeth out. So again, if these were unprepped teeth, I would not be doing as much facial reduction. Unfortunately, these teeth have veneers on them. So I'm going to go ahead and do my mock-up. I got my material. I go ahead and seat my tray. I just dry the teeth and put it right over there, right over the teeth. Let that set for a minute. We take that out. And now we got our mock-up. So this is basically, you hear that saying, start with the end result in mind. Well, this is starting with the end result. You're basically starting exactly where you were, where you would like to be at the end. And what we do is we're going to go ahead and we're going to depth cut right through this mock-up. First, I'm measuring my central, and I want 11 millimeter central. And I'm measuring that just to make sure that's where I'm going to be. And that's where I am at 11 millimeters. Go ahead and anesthetize the patient. Don't need to really see that. This video was done. Okay, now we're doing our, this is the 3 cylinders, 3 cutting cylinders, okay? We use this sometimes too. This didn't really matter because, like I said, we've got veneers underneath here. This is more for demonstration to show you how we do it. So then we would go ahead and we would color these in. But because we're going to be building these out, and there's porcelain underneath this mock-up material, you're going to see that this color kind of just wipes off here. But this gives you an idea of how we do this. Okay, we make our depth cuts, we cut it in. Now what we're doing is we're just taking away the mock-up material. And then what's left in the colored in depth cuts are what you reduce facially. So we're going to come back here and we're just going to start doing our facial reduction. And this is pretty straightforward. Just to kind of give you an idea, just show you a couple of things real quick here. So we're just smoothing everything out. Again, we're taking off old veneers. So basically, I'm prepping it like it's a veneer. Nowadays, it'd be harder to do if you're using lithium silicate or something. But in the old days, the feldspathic porcelain, you could prep it almost like you were prepping tooth. This is kind of what we do. We just keep the burr flat against the tooth, and we use the tip of the burr to create a chamfer as we follow the gingival margin. And then when we get to the end, we're going to come in here, doing our elbow. We're creating our interproximal elbow there. We're doing our premolars. Very minimal preparations. And then we're going to come back and we're going to use our disc to round everything. Well, first we're going to do just some interproximal smoothing. We take these finishing strips and we go in there and we don't break contact. So we're going to go in there and we're going to smooth everything. Now this is I love the Super Snap Shofu discs. These are great discs. They don't have a mandrel in the center. I like them. They have 4 different grit sizes. And all we're doing is just rounding the corners, rounding the incisal ledge. The facial incisal ledge, we're rounding that towards the lingual, so there's no sharp internal line angles. These are really nice discs. I like these Shofu discs a lot. And then we're going to go ahead. This is our natural dye material, ND shade. And we're going to go ahead and take an ND shade. This is part of our laboratory communication. They want to see the shade of the prepared teeth. And we're going to go ahead and take a picture of that. And that's part of our laboratory communication, along with our provisionals and all the other information you get. So speaking of provisionals, so when I say the key to success, it is. I think the provisionals are probably the thing that are going to help you the most because they're such a valuable communication tool. And when I say these, by the way, these are provisionals here. I say that, I'm sorry, I've got my, I'm going the wrong way with my advancer here. Sorry, these are actually provisionals. These are not, and this was actually done in one of our hands-on programs. This is a dentist that took our hands-on program many years ago, and these are provisionals. And because it was such minimal preparations, this is at the end of the prep visit after the provisionals are made, and the patient had such little local anesthetic because there was very little tooth preparation at all. The patient was able to smile pretty good, and we went ahead and got these pictures right at the end of the case. But you can see if you have a patient that comes back to you and says, "I love my provisionals," then so much of your work is already done because the laboratory uses this as a guide to copy. You take pictures, you take impressions. The patient's already said they like them, they're happy with how they look. Then you're well on your way to having a successful result. So they're the tip. We call it the trial smile in our office. It's the template for the final. The laboratory can be incisal edge, length of centrals, color, shape and arrangement. All these things are important. And all of it's communicated to the laboratory as our main communication tool by pictures and impressions of the provisionals. But the patient communication is so important because it prevents you having problems at the end. And so, are they too short? Are they too long? Are they too dark? Do you like one side better than the other? All this information is valuable. And once the patient says, I really like my temporaries, and once they say, I'm happy with these the way they look, then you take, you have a pretty good idea that they're going to be very happy with the final restorations because they've already approved the provisionals, and the finals are always going to be better, a little bit better. But here's the other thing so the reason we don't feel like we have a lot of problems post-op is because we work it all out in the provisionals. So we can evaluate aesthetics, just like you saw in that picture a minute ago. The patient was happy. They give you a thumbs up. They say, I really like them. So you work out your aesthetic issues. But we also work out our functional issues. We do our, we can check the bites. We can check excursive movements. We can check all these things. If they're not breaking provisionals, and they're not having a problem with their provisionals, chances are they're going to do really good with the finals. And we also can check phonetics. Can they speak? Sometimes we're increasing incisal length on these teeth. So we want to make sure that it's not going to affect speech. So we check things. We have them say 55, 44, things like that. And we're able to go ahead and really get a good idea of what we're expecting to have from the final restoration. So these three things are so important. It's working everything out in the provisionals. So there's an intraoral lock-on technique and extraoral finishing. The intraoral lock-on is what we use for porcelain veneers. When we don't break contacts, it's very hard to finish these out of the mouth, which we do with the extraoral finishing technique. So we just like to lock them right on the teeth. It's simple and it's easy. We clean the preps. We spot etch. Again, we want them to stay on, so we want to spot etch right in the center of the tooth. We lightly air dry. You're going to put some kind of, you don't want to use universal adhesives or anything that has that can self-etching. You want to use an unfilled resin. The old 4th generation bonding, the bonding only liquid. That's all you want because you just want it to adhere to the spot etch and nowhere else on the tooth. You put the material in the putty matrix, seat over the preps, allow it to set. You remove the matrix. Any excess, you adjust occlusion, shape, contour, polish, and apply glaze finish. So here it is. Let's go through this really quick. So we're putting our spot right in the center of the tooth. So we want it to bond right there, but we don't want it to bond near the margins. Okay, so we're going to rinse this off. You can use any 4th generation adhesive, the second bottle, not the primer, but just the adhesive. We rinse all the etches off. We're going to lightly air dry these teeth. Now we're putting a little chlorhexidine on there. This is an extra step if you want. It's a little antimicrobial. Sometimes it cuts down on micro leakage on your provisionals. We dry that on there. Then we're going ahead and we're paint our adhesive. Light cure. Put our material in the teeth, in the putty matrix, seat it over the teeth. This time we do want them to stay on, unlike the mock-up. Same steps as the mock-up, only this time we spot etch. We take that out, and there's our, now look how great those look, and that's mainly because of the wax up. We had a beautiful diagnostic wax up here. Like I said, my laboratories, they have a waxer, Jason, is just phenomenal, and he does incredible wax ups. We do a lot of full mouth rehab cases where we're opening bites, 24 teeth, and just amazing the results we get. Now, if you get a little bubble, it's a little flowable composite, and we just put that in there just to kind of go in and fix that bubble. Then we're going to go ahead, like cure that, and then we're going to polish and add our glaze. So now the patient comes back. I'm going to run through this really quick. This is the patient coming back for their post-op. Now, these are the provisionals, usually a couple of days later. We're checking for bite force. This is a T-scan by a company called TechScan, and all it does is measure bite force. And what we're looking to see, this is more valuable on the big cases where they're full crowns or where you're really doing a lot of occlusal. These are minimal prep veneers, but what we noticed here is the second molar she was hitting high on. That was her answer when I asked her, did you like your teeth? She gave me a little wink there saying, yes, I like them. She's smiling really big, which is always a pretty good sign. Now she's doing phonetic exercises. 44, 55, 66. We're going to check that second molar now and probably adjust it a little bit because the T-scan showed she was sitting high. You can do this with articulating paper. It's just nice to have something to check your your bite force to see, are they hitting on restorations with too much force? Are they hitting on a tooth somewhere that just needs to have some minor equilibration done, which is exactly what we did there. And again, this is a step I do with the full mouth cases, the full arch cases. I like to have them simulate their envelope of function. So we have them sit up and chew on articulating paper, which you'll see that here. This is an example of what I'm talking about. Okay, so this is extraoral finishing technique. So notice that we don't lock them on because these are like full crowns. This is a full arch. So we went ahead and we tried the uppers. We've already made the uppers. This is again from a diagnostic wax up. Now we're going to go ahead and make the lowers. And we're going to get these out. Now we're going to put a separating medium on the teeth because we don't want them to stay on the teeth. Okay. So we want them to come out in the matrix because we want to trim out the margins and then we want to cement them on with a temporary cement. So here we are. We're just teasing it out of the putty matrix. We take this out. We trim away the excess. And we'll go ahead and try that in. Now you can put it in all in one piece. This is 12 teeth on the top, 12 on the bottom, or you can separate it into posterior segments and an anterior segment, whatever you're more comfortable with. We go ahead and seat those in. Now we have the patient closed down, and we're going to see, hopefully they're hitting everywhere. Now this is just, I haven't touched anything yet, okay? We just put the upper and lower in. Look at that occlusion. This is not me. This is my laboratory. What an amazing job that they did with this diagnostic wax up. This is an open bite too, by the way. We opened her vertical dimension a couple of millimeters in the back to give her the room in the front. Now this is where this technique really, I think, is beneficial. We want her to simulate her chewing mouth. Now, obviously, she's still numb. We're going to get her back and do this again at our post-op check, but I like to send them home as close as I can get them. And so what this does, it simulates a chewing motion. So I can look in there and I can see where we need to adjust and what we need, where we are. And so we're going to try to get, as the late, great Pete Dawson said, you want dots in the back, you want lines in the front. And that's what we're looking to do. Where those smudge places are, we're going to do some minor recontouring there. All right, so that moves us on to smile design. I got about 20 minutes to do these next two segments, so we're moving along here. Thank you for bearing with me. Okay, so combining art and science. Smile design principles: central incisors, midline, axial inclinations, arch form, smile arc, gingival height symmetry, gradation, and buccal quarters. So let's go through these quickly here. Again, I'm just hitting the high points here. Central incisors, I can't say this enough. That's why I mentioned it twice. Incisal edge position of the central incisor is the most important determinant in the creation of a smile. But central incisors also have an individual tooth proportion. So again, you see this quote again from Gilly Burrell, and I can't stress it enough. I think how important it is determining incisal edge position and making sure it's right. But the incisal edge position and gingival margin placement affects the length of the tooth. And the width of the tooth and length of the tooth combined gives us a height to width ratio. And that height, the ideal length to width ratio, is somewhere around 75 to 80%. And this becomes very important when we're looking at these cases, especially the aesthetics of our final restorations. And the midline is so important because sometimes the dental midline isn't right in the center of the smile. So here you see the yellow line is the facial midline, and the red line is the dental midline. The dental midline in this case is just right in the center of the smile, which is coincidental with the facial midline, which is fine when it's in the center of the smile. But notice what's most important: that dental midline is perpendicular to the horizontal plane. It's not canted one way or the other. So as long as the dental midline is perpendicular to the horizontal plane, it doesn't matter if it's in the center of the smile. As you see in this case right here, here's the facial midline, here's the dental midline. You've got a midline shift to the left of a couple of millimeters. And the reason it doesn't show to the eye is because it's perpendicular to the horizontal plane. This is the critical thing about the midline. It does not have to be in the center of the smile. It just needs to be perpendicular to the horizontal plane. That's why we take face bows and stick bites, and we take pictures and all this stuff, because the laboratory needs to have a reference to the horizontal plane, and that's what the stick bite will show them. So it's very important in laboratory communication, the stick bite. We go through all of that in more detail. Axial inclinations are the way the teeth arrange themselves around a central axis. So you notice there's an ever so slight mesial inclination of these teeth. When teeth have this slight, especially if they're inclined distally, it's always going to affect the eye. So maybe it already exists, If not, you can correct it orthodontically. Sometimes you can correct it with a restoration, and sometimes you can actually do it with tooth preparation, which we get in, we show you how to do. You can actually take a good axial inclination, because when we prep teeth, in our courses, we always teach the dentist, we always talk to them and say, be sure when you're prepping multiple teeth, get up and go around in front and look at the patient from in front. Because when you do that, you can see if sometimes you angle your burr slightly, you can change the inclination of the tooth. And you might make a tooth that's in the right inclination, you might angle it too much mesially or somewhat distally. So you can change a distal inclination by holding the burr mesially. So it's a minor movement, but it can be accomplished. Arch form there's 3 arch forms. You got the ovoid, the tapered, and the square. The most important thing is what we want for aesthetics, and in these aesthetic type cases, we want the ovoid arch form. And if we don't have it, we want to correct it either with restorations or hopefully maybe in cases like extreme cases like you see in this middle case right here, orthodontics, and even in cases like this, minor tooth movement might be beneficial before you go ahead and you do your restorations. Whoops. So the smile arc is the curvature of the incisor, the incisal plane. It should be parallel to the curvature of the lower lip. Okay, this is what's called the smile arc. If in females, you're going to see more curvature to the lower lip, so you're going to see more curvature to the incisal plane. And males tend to have more flat lip, and you see when they have a flatter lip, you don't have as much curvature in the smile. But it's important that the incisal edges be parallel to that lower lip curvature, especially in females. So you see 4 different restored. These are 4 cases, all females. You see they all have nice curvature of the lower lip. And you notice in all these with 10 veneers, all of them they're all parallel to the curvature of the lower lip. Some of them are touching the lip, some of them aren't. Some of them are part of them are touching, some aren't. That's not what's important. What's important is that you see the incisal edges parallel to the curvature of the lower lip. And this creates symmetry, which is pleasing to the eye. This patient came in and was unhappy. She'd had 12 Emax crowns bonded on and was not unhappy with the color of the teeth, and the shape was okay, but there was something about the smile was bothering her. So she doesn't know what smile arc is. So when she smiles for me, instantly I could see she has a flat smile arc. So what I did is I just said, well, let me show you something. So we went ahead and we put some composite on her teeth, and just the 4 incisor teeth, just to give her a little bit more length there on those incisors, to show her what the proper curvature, a consonant smile arc would look like. As soon as she saw that, she instantly wanted to do it. So the way we treated this case is I didn't want to drill off. If anybody's ever had to drill off bonded Emax or bonded zirconia, they know what a nightmare that can be. So these crowns are relatively new and they had good margins. So we just went ahead and just did veneer preps right into the crowns and just did 4 veneers on 7 through 10. And we bonded in 4 veneers onto her crowns. And here was our final result. So we went from here to here, and a much, much happier patient. And the great thing about this is I never had to, this is immediate, the full face on the left is immediate post-op. This was right after we finished the case because we didn't have to number up. We went ahead and just took the picture of her smiling. She was pretty happy. Just to show you the importance of the smile arc. Gingival height symmetry, sometimes referred to as the high, low, high. The centrals and the canines should be on the same plane with the laterals slightly below. Males is maybe a half a millimeter. Females, I think it's more aesthetic sometimes to create dominant centrals. If you have the laterals about a millimeter below that would be ideal. But here we see a case, a restored case. Again, patients come in unhappy with their smile, some recurrent decay, some failing margins, a temporary crown, some issues going on. So we go ahead and restore this case. Now we could have gone in there and just left the margins right where they were, okay, and made nicer looking restorations and got rid of the recurrent decay. But at the same time, we went ahead and we want the teeth to be, the central should always be the same length. You don't want one longer than another. So we go ahead and we go in here, but again, we create better gingival height symmetry, which I think is important. And you can really see for somebody with a high smile line, you think, well, if they don't have a high smile line, that doesn't show, it's probably not important. I won't argue that point. But what about somebody that does have a high smile line? This is not ideal gingival height symmetry. So by creating better gingival symmetry with a high smile line, you see you're able to create a better result. So gingival symmetry with somebody who shows it when they smile can be very important. Principle of gradation is front to back progression. You just want teeth to appear to get smaller as they go distally in the arch. So the left side here, you see this is ideal. And the right side here, you see this is a gradation violation right here because this tooth should not be smaller or appear to be shorter than the tooth behind it. So these are important concepts to understand, which we go into a lot more detail when we talk about these cases. Buccal quarters simply is the space in the corners of the mouth. You see from the facial of the tooth to the corner of the mouth, we call this negative space. And when you have a lot of negative space, it creates an anesthetic result. So it's the reason why so often it's beneficial to the patients, especially female patients, to do 10 teeth. Not only are you decreasing negative space, which gives them more attractive smile, but you're giving lip support, soft tissue support, and patients, especially as they get older, they really like this because it gives them a kind of a non-surgical facelift where it decreases wrinkles and lines around their mouth, and it really can make a dramatic result in giving the patient a more youthful look. So sometimes it's extremely beneficial to not do 4 or 6 teeth, but to do 10 teeth. Okay, moving right along, we're doing pretty good. So now we're into the last segment and that is how do you bond these non-retentive restorations on? Okay, and I think this is something that, you know, it can be a very stressful appointment. Okay, and here we are at our steps. We evaluate, we try the restoration on a stone model. If available, nowadays we don't always have stone models if you're scanning, but in the old days, we always tried them on the model just to see if they set passively on the model. Then we're going to go ahead, we anesthetize the patient, we remove the provisionals, and we floss the contacts. We go ahead and we use some hydrogen peroxide to clean the preps. We try the restoration with water because we want to evaluate fit and contacts, okay? So you can try them on individually, but we want to try them on all at the same time because that allows us to really make sure they fit and we have good contacts. They sit passively. If you have any hemorrhage, you have to control it before you start bonding. Any bleeding will cause, you can get micro leakage and discoloration. We're going to isolate with a rubber dam. I'm going to show you how we do that. We're going to clean preps with an antimicrobial. We etch, rinse, and we apply multiple coats of universal adhesive. We air dry and evaporate solvent and light cure. Place light cure resin cement on preps. It's so much easier to handle veneers if the cement is on the tooth and not on the restoration. And I'm going to show you exactly how we do that. We clean the excess cement with cotton rolls, brushes, tack restorations, floss contacts, and light cure. By the way, these things, you can get a copy of this with all this information on there, so you don't try to write this down. We're going way too fast. Remove the rubber dam, adjust occlusion, and polish. So how do we prepare glass? So that's how we get the teeth ready. So for glass ceramics, if you're using lithium disilicate, okay, which is the most popular glass ceramic right now, Emax or GC's Lisi Press or something like that. So lithium disilicate restorations, you're going to go ahead. You can clean glass with anything like phosphoric acid, okay? Or you can use acetone, a water bath, whatever. You rinse, you dry, you've got to apply silane. You want to have silane. It's going to increase your bond strength exponentially. So you have your acidic, your etched surface that comes from the laboratory etched. If you're milling in your office, you're going to have to etch with hydrofluoric acid. Hydrofluoric acid. What did I say? Yeah, not phosphoric, hydrofluoric acid. Okay, allow for sit 1 minute. So after you place your silane, before you dry, you need to let it sit for a minute. And then you paint the silane surface with a bonding agent. Don't cure it. You just put it on there to wet the surface to get a better bonding adherence to the cement. Set aside, organized by tooth number. If you are doing zirconia or you're bonding zirconia, it's important to understand it's different from glass, okay? And you cannot clean zirconia with phosphoric acid because of its affinity for phosphate groups. You need to use a ceramic cleaner like Bisco Zirclean. 30 seconds, rinse and dry. That's all you have to do to clean zirconia. Then you want to air particle abrade it, and then you want to apply a ceramic primer, okay? This is like Z Prime Plus from Bisco. This is a ceramic primer that I use. This allows you to bond zirconia, and then you place your resin cement. So that's the difference between glass and zirconia, and I think it's an important distinction to know that you have to clean zirconia different from glass, and you have to use a primer, and silane will not help with zirconia, but it does with glass. So let's go ahead. And what I'm going to do is I thought it'd be good to show you a video of us going ahead and seating 10 veneers. This happens to be at the Greater New York Dental Meeting. This is a live presentation. I just mentioned a minute ago that this could be kind of stressful. So it's probably the last thing you want to do in front of an audience, but we went ahead and did it because I have a lot of confidence in my laboratory that they would make great, great fitting restorations, and that my patient was going to have healthy gums and all that kind of stuff. So anyway, here we go. So I've got to wait just a second for me. You don't need to hear me speak twice. So they've got a microphone on me and I'm talking. I'm going to show you how we put a rubber dam on. So we're taking wingless clamps and we're going to go ahead and we're going to clamp the first molars. Everybody says, I'd use a rubber dam, but it takes too long. Trust me, it does not take long. I'm going to go ahead and show you this in real time so you can see just how long. All we're doing, we've already got the rubber dam ready. The rubber dam is on the frame and the holes are already punched. Now I see the clamps are on the first molar. They're wingless clamps because I'm bonding to the second premolars. So we don't want the wings getting in the way. So we're going to go ahead and we're going to take our rubber dam and we're going to we cut a straight line between the two holes about an inch apart. And I'm just going to walk that around the back of one clamp, pull it up underneath the lip and walk it around the back of the other clamp. Okay. So now we do this. Fold it up underneath the lip, make sure it's not covering up their nose. And then we can take some cotton gauze and we put it in that little hole in the palate right here, seal that up in case you were to inadvertently drop a restoration. You don't have to worry about the patient swallowing. And that's all it was. In a very short period of time, we now have the lips out of the way. We're working hands-free. We got the teeth isolated. We've got moisture control. We've got bleeding control. We've got everything we could possibly want to make this a simpler procedure. So the rubber dam to me is the first step always, and it's critical when bonding multiple restorations. So now we're going to go ahead and we're just using some chlorhexidine here to clean the preps. There's a lot of studies and research out there that will tell you that acid activates MMPs, matrix metalloproteinases, and that antimicrobials like in sepsis or something like this will help deactivate those MMPs, which break down collagen, which is not a good thing. So they're basically enzymes that break down collagen. So we want to do anything we can to help us in that regard. We also will use, I like Bisco's Select HV etch. For my etch, it's HV stands for high viscosity. It stays right where you put it. It also has BAC, benzalkonium chloride, which is another antimicrobial right in the acid etch. So we put this on 5 teeth at a time. We rinse it 5. I don't want it on for more than 15 seconds or so. So we're going to etch 5 teeth and rinse, 5 teeth and rinse. So we don't etch more than 5 teeth at a time. And I rinse in the same order that we put the etch on. So now we're going ahead, we're etching all the teeth. We do the other 5 teeth and we rinse. Lightly air dry. This is my favorite adhesive. This is All Bond Universal by Bisco. I love Universal adhesive. I could talk for an hour on why I'm such a fan of Universal adhesive. Suffice to say, I don't have that much time. But trust me, if you're not using universal adhesive, I can't tell you how much easier it'll make life. You can use it for total etch, self etch, or selective etch. It's a single bottle. They work great with everything. We're just putting multiple coats, making sure we get, if there's some dent exposed, we're making sure that we've got, adhesive into the depth of our etching. We're going to lightly air cure, and you have to light cure your adhesive. It has a very thin film, less than 10 microns. It will not interfere with the seat of a restoration. You do not need to worry about that. So we go ahead and we light cure this after we evaporate the solvent. Notice we got pretty good tissue control, but one little spot right there, that's a micro brush with some superoxol, a little mini pearl there. If you get a teeny little bit of bleeding right there, we take some superoxol on a micro brush and touch it right there. Overall, the tissue is pretty healthy. So now we evaporate the solvent, dry the teeth till nothing moves, lightly blowing air. And now we're ready to go ahead. Whoops. Now we're ready to go ahead and seat the veneers. Now what I'm using, well, uh-oh. Did I go backwards? Yep, sorry. Here we go. So what we've done, so we put our adhesive on, we've light cured, now we're ready to cement the veneers. So this is Shofu's Beautiful Flow Plus. It is my favorite. I love flowable composites, so I've just used a flowable composite. Again, we're just touching the microbrush right there. You notice we have the gauze in there, so we're protecting the palette. Beautiful Flow Plus, and now they have Beautiful Flow Plus X, which is even better. It has two flow consistencies, and it has their gyro. I've talked about ion release. It has their gymer technology, which releases 6 beneficial ions. So Shofu has some great products, and this is one of them. And so we're using Shofu's Beautiful Flow Plus to seat our veneers with. This is the low. It has a no flow and a low flow. We got the no flow on there because it just stays right where I put it. So we're going to go ahead. Notice that this little tip, it makes it easy to coat the teeth with this little tip right there. Now we start seating the restoration. Once we have all 10 teeth covered, now I did have a little bit of stress because they're videoing this and they had to leave some lights on the video. Normally in my office, all the lights are out. There's no lights on right now. So we're going to have to work a little bit quick here because they couldn't turn the lights out. Otherwise, they couldn't be able to video it and the audience wouldn't be able to see what we're doing. So there's some lights on. We're just making sure we get them all seated. So now all 10 are on. So again, this is my laboratory. This is Gary Vaughn, who's a phenomenal ceramist. I've worked with Gary for over 20 years. He's not just a great ceramist, he's a great guy, a really good human being, a class act. And he does beautiful work. And he made these veneers and he knew I was going to be putting them on in front of an audience. So I think he really went all out to make sure they look good. And he did. And they fit great and they look great. So we're cleaning away the excess. Only place we can't clean is interproximally. So what we do is we tack. So I'm holding the incisal edge. It's got that little lip on it. And then I'm holding the curing tip, the tacking tip at the gingival margin to seat that way. And as I do that, Christy's wiping away the excess. If there's a little bit of excess exudes out while we're holding the veneer down, but I'm tacking it. Then after tacking these down, I can come back with my floss. And the only place I couldn't get before was interproximally. Well, now they won't move. So I can come back with my floss and I can go ahead and get my floss. Now, what I don't do, this is another little mini pearl. If you can't get your floss, don't force it. So what I'm doing is, and again, this was hard for us because of the operatory light, those overhead lights are on. So this is a little metal serrated blade. I just go straight, I don't saw, I just go straight down and straight out. And then once I do that, I can go ahead and come back with my floss, and usually my floss will pull right through just like that. So once I floss all my contacts, we just light cure. And then, well, okay, I'm going to go ahead and quit. That was basically it. Then we just adjusted occlusion and polish. So I'm going to open it up to questions now, Lisa, if that's okay. I'm sorry for that little bit of delay. Ran over just a minute or two, but hopefully it'll give some time to answer questions.
Absolutely. So we have a couple in the chat and one in the Q&A. So I'm just going to go ahead and start here.
Okay.
How did you bond veneer to zirconia crown?
Okay. Thank goodness I didn't. I don't want to bond to zirconia. You can bond to zirconia, but those crowns were glass. They were lithium to silicate. They were Emax crowns. And you can bond to glass with a very high bond strength. In other words, we have to etch the crowns in the mouth. We isolate the gums and we put hydrofluoric acid on the crowns, and then we put silane on them, and then you can bond to glass. You can get a great bond to glass. I've been bonding to glass in the mouth. I learned this technique from Larry Rosenthal when I was teaching with him with Aesthetic Advantage over 20 years ago, of bonding to, there'd be like a premolar crown, and it was a relatively new crown, but we want to build out in the buccal quarters. And he said, why would you want to cut off a perfectly good crown? He said, you can just veneer that crown to build it out facially, so you're filling out the buccal quarters. So I learned this technique many, many years ago, that you can bond to glass in the mouth. And that's what I did. Those were not zirconia crowns. It's a good question. If zirconia, you can do it. I just don't like bonded zirconia. I don't get the bond I get to glass for some reason.
What flowable shade do you use?
I use B1. I just like it. It gives the veneers. You can use a neutral shade. And if you use a veneer cement, a lot of them will have a clear shade or a neutral shade, especially if you like your teeth. But I don't know, for some reason, I think in a very thin veneer, I teeth discolor, they get darker with age. And I like, even though they may look great at first, I like a colored veneer cement. That's just my personal preference. So I just use B1. It just seems to make them really pop and just give them a nice color. And I feel like, I see veneers 15, 20 years later and they still look really good. And I think having a colored cement underneath there with some type of a little bit of a lighter shade, I think helps that.
What are your thoughts about molecular iodine instead of chlorhexidine?
Well, that's something I'd have to defer to somebody smarter than me. Molecular iodine, I'm not familiar with that. It sounds to me like it's probably pretty good, but unfortunately, I don't have the knowledge to answer that question. But molecular iodine sounds pretty impressive. I just know chlorhexidine has some good research behind it, but anything that works and anything that has research to back it up that shows it can be beneficial, I'm in favor of.
When there's composite, oh, I just lost it, hang on. When there's composite in the interproximal surface, would you place veneer margin on the composite?
I like to not place veneer on composite. I learned this a long time ago too. You're going to get better bond. You get a healthier bond, let's put it that way, from veneer to tooth as from veneer to composite, because now you have two composite layers. You have the composite restoration, you have the composite cement. So I usually will take out composites interproximally, usually, okay? And that way I'm bonding straight to tooth. And so that's a case where I would probably break contacts if there's class 3 restorations interproximally. That's a great question. It's something that we cover in more detail if we're not trying to cover 4 hours in 1 hour. I'm so happy that that question got asked.
Hello from Mexico. My question is, what is your favorite try-in paste?
Hola. To be honest with you, I don't use a lot of try and paste, and I'm going to tell you why. If I have a color, I've been doing this for so long, I kind of know the color I want. In fact, I don't even have to ask my assistant, who has a great eye for color. She'll actually she's very artistic and she has a very artistic eye. So she will tell me. But if I were going to use a try and paste, only thing you got to make sure is it gives you the same color of a cured veneer and that it's water soluble, that it rinses off easy. It's just an extra step and it kind of lengthens the process out. And listen, the last thing I want is something once I get those temporaries off, I'm wanting to get the veneers on as quickly as possible. I know this may sound, but the longer the tissue stays exposed, the teeth stay exposed, all these kind of things, it's adding time to the procedure. I like to get everything off and then get everything on as quick as I can. I have no problems with try and paste, but it's usually because you're trying to make a color shift for some reason. But make sure it's water soluble and make sure the color of the try and paste matches the shade of a cured cement.
Do you do the T-scan before and after provisionals?
Yes, you can. The great thing about the T-scan is it'll measure bite force on your provisionals and also measure bite force on your final restorations. So it can be a really good, way of checking yourself and checking to see, and I'm not saying there's so many dentists out there that fine tune occlusions without a T-scan, but I'm just telling you, if you really want to dial it in and be very accurate, T-scan is a great way to do it.
Okay, I have a couple questions here on what lab you use. So it is Core Dental Designs. It's
Court,
in
yeah.
the chat, but I
Yeah.
will go ahead and
Yeah, I
uh,
can't listen. I, the great thing about this webinar is that when I'm lecturing, I don't promote anything in a lecture. Okay. When I'm asked to speak somewhere, but this is different in a webinar. I'm happy to talk about, my laboratory because they've been so good to me for so many years. There, like you saw some examples there, the wax up there is, what a phenomenal job that Jason does there. And Gary Vaughn is just a great ceramist. And Garrett runs a very, very, a great laboratory that will do anything for the dentist out there to help you in any way they can.
okay. Next, if there is gum recession, would you go subgingival?
So If there's gum recession, I wouldn't go subgingival, okay? I would basically, if it shows, I might take to the gingival margin, or I might do something like Shofu has peak composite, and sometimes you can make the margin to where ideally you want it to be, and then you can take that receded area and you can fill in some peak composite right there. That's a technique that hasn't gained enough notoriety yet, but I think as time goes on, I think you'll see more and more dentists matching the pink of the gingiva and then having the white of ceramic. We've done a lot of pink stuff, pink porcelain and pink composite in certain cases with extreme recession. But no, I wouldn't make my margin subgingival because I don't want to do anything to make the gingiva recede even more. In fact, ideally, I'd like to stop short of the gingival margin.
In crowded cases where patients don't want ortho, how do you do a mock-up for the patient to see what the end result might be? Do you ever use an iPad to draw on it? What do you do?
Yeah, it's hard to do a mock-up. I mean, you could do a digital mock-up, and show people if you do digital. I could do mock-ups pretty fast, so I can usually do them in the mouth. If it's really, so here's my thing with crowded. I just say no. If it's a young patient with healthy teeth, I just say no. Just like, the saying goes, just say no. If it's an older patient with restorations and, I don't make them see an orthodontist. But if it's a young patient with healthy teeth and they're crowded, I just say if they're not going to see an orthodontist, I'm not going to try. I'm just sorry. I'm not going to drill perfectly healthy teeth just to get them straight on a young, healthy teeth. But if it's an older patient that's got, broken down teeth or a lot of restorations or something like that, sure, we'll do a mock-up. You can do a mock-up on crowded teeth. You can do it. It's just if it's just not extremely crowded. If they're extremely crowded, then that's another thing, but that's got to be addressed different ways. And it's a lot of time is don't have time to discuss all of that here now, but a lot of it is your relationship with your patient and your communication ability more than likely. But if it's not too bad, I can do a mock-up on it. And your laboratory can. Your laboratory can do it. What they'll do is the great thing about a laboratory, especially like court, they'll mock the model. They'll mock up the model. So they'll prep the model and they'll show you where they prep the model to do the wax up, and they'll show you exactly what you need to do in the mouth. So that could be a really beneficial thing to you. And again, this has to be an older patient that doesn't want ortho because of the condition of their teeth, and because you're not destroying healthy tooth in a young patient. I hope I didn't offend anybody by that answer.
Was clinical crown lengthening done before the prosthodontist to establish proper gingival contouring?
I don't think I showed a case with crown lengthening. That one case I showed on the young female patient, we raised her gums because she had basically pseudo pockets. She had pockets. We were able to do it with just a gingivectomy. But if we need to, if it's going to invade biologic width, we always do crown lengthening. I have a great periodontist I work with. He's phenomenal. So we do in some cases, yes, we do crown lengthening to establish gingival height symmetry in cases where we'll get biologic width violations if we don't.
For dark tetracycline teeth, do you do veneer or full crown?
Okay, this is a really good question, and it depends. So tetracycline can run the gamut from extremely dark to just kind of dark, okay? So it really depends on how dark it is, but I'll tell you what I'm doing with tetracycline now. Often tetracycline is banding, and this technique has worked really well for me. I'm going to do a veneer prep, and then I'm going to go in there after the veneer prep, and sometimes I'll break the contacts a little bit too. But I'm going to go in there and I'm going to take the banding out with a burr, and I'm going to come back and layer composite in. This is one time I will bond composite to composite. I know I'm contradicting myself. A minute ago I said if it's a class 3, but I'm bonding it on the facial to lighten or bring the value up so my ceramist doesn't have to block it out with the restoration. So I actually lighten the tooth with a layer of composite over it, and then I try to bring the value up of the tooth. So it makes it easier for the ceramic to use a more translucent porcelain, because if you want an aesthetic restoration, it needs to be more translucent. And we're not doing a lot of feldspathy anymore, which they could blend shades to kind of block out some of that color. We're mostly now with milled and pressed restorations. It's a little bit trickier to do. That's why I like to raise the value. It's a really good question about tetracycline. It just depends on how dark it is, if it's banding or not. Is it in the gingival third where the restoration is usually the thinnest? You got to go a little bit deeper. Would I do a full crown? Probably not, but I wouldn't argue with somebody who did. My thing is, if they've got really dark, really bad teeth, you more than likely, wouldn't you rather have a good final result? And if you mean sacrificing a little bit of tooth, I know if it were me, I'm going to sacrifice tooth to get a better result. If it is a member of my family. So I'm not against sacrificing teeth in extreme situations, okay? Because if you do a minimal prep and you end up with a dark, or an unattractive restoration, have you really helped that patient? So it's a tricky question. It's hard to answer in a short period of time, but do what you feel like is best to get the best result you can get with your restoration.